Question 1. A 45-year-old carpenter presents with gradual onset of numbness and tingling in his thumb, index, and middle fingers, especially at night. He reports dropping objects more frequently. What is the most likely diagnosis? A. Cubital tunnel syndrome. B. Carpal tunnel syndrome. C. Radial tunnel syndrome. D. Guyon's canal syndrome. Answer: B. Carpal tunnel syndrome. The concept being tested here is the identification of common nerve compression syndromes based on sensory and motor symptoms. The keywords numbness and tingling in his thumb, index, and middle fingers and especially at night are classic indicators of median nerve compression, which occurs within the carpal tunnel. Carpal tunnel syndrome is a condition where the median nerve is compressed as it passes through the wrist, affecting sensation and strength in the digits it innervates. For instance, a patient might report waking up with a numb hand that feels asleep. Here's an easy way to remember it. Think of the median nerve as supplying the middle of the hand, thumb to radial half of ring finger, and night symptoms are very characteristic of compression. Question 2. When assessing a patient with a suspected scaphoid fracture, which special test would be most appropriate to perform? A. Finkelstein's test. B. Phelan's test. C. Watson, scaphoid shift, test. D. Grind test. Answer: C. Watson, scaphoid shift, test. This question evaluates your knowledge of special tests for wrist pathology, specifically for scaphoid injuries. The keyword scaphoid fracture points directly to the need for a test that assesses scaphoid stability or pain. The Watson, scaphoid shift, test involves applying pressure to the scaphoid while moving the wrist from ulnar to radial deviation, eliciting pain or a thunk if the scaphoid is unstable or fractured. This test helps confirm the clinical suspicion of a scaphoid injury, which is critical due to the bone's precarious blood supply and risk of non-union. For example, if a patient fell on an outstretched hand and reports radial-sided wrist pain, this test would be highly relevant. Remember, the Watson test is specific for assessing the scaphoid and its stability. Question 3. What is the primary purpose of a dynamic splint? A. To immobilize a joint completely. B. To provide a static stretch to soft tissues. C. To apply a continuous, low-load stretch or substitute for absent muscle function. D. To protect a surgical repair by preventing all movement. Answer: C. To apply a continuous, low-load stretch or substitute for absent muscle function. The concept tested is the function and purpose of dynamic splinting, which contrasts with static splinting. The keyword dynamic implies movement and force application over time. Dynamic splints incorporate elastic components, springs, or rubber bands to provide a consistent, gentle force aimed at increasing range of motion, example correcting a joint contracture or assisting weakened muscles. Unlike static splints, which hold a joint still, dynamic splints allow for controlled movement or passive stretching. An example would be a dynamic extension splint for a boutonniere deformity, which gently pulls the PIP joint into extension. Always remember that dynamic splints are designed for movement and gentle, continuous force application. Question 4. A patient sustained a zone V extensor tendon laceration and underwent primary repair. What is the typical splinting position to protect this repair immediately post-operatively? A. Wrist in 30 degrees flexion, MCPs in 70 degrees flexion, IPs in full extension. B. Wrist in 45 degrees extension, MCPs in 0 to 10 degrees flexion, IPs in full extension. C. Wrist in neutral, MCPs in 90 degrees flexion, IPs in full extension. D. Wrist in 20 degrees flexion, MCPs in 30 degrees flexion, IPs in 20 degrees flexion. Answer: B. Wrist in 45 degrees extension, MCPs in 0 to 10 degrees flexion, IPs in full extension. This question tests knowledge of extensor tendon repair post-operative protocols, specifically for Zone V injuries. The concept is protecting the repair by minimizing tension on the healing tendon. Zone V refers to the dorsum of the hand, covering the extensor tendons over the metacarpals. To relieve tension on these tendons, the wrist should be placed in extension, and the MCP joints should be held in slight flexion or nearly full extension, with the IP joints fully extended. This position, often called the safe or intrinsic plus position, helps keep the extensor tendons shortened, preventing disruption of the repair. For example, a patient with this repair would wear a custom orthosis maintaining these angles. Remember, positioning in extension for extensor tendon repairs is crucial for protection. Question 5. Which of the following is the most appropriate initial treatment for a patient diagnosed with lateral epicondylitis? A. Immediate strengthening exercises for wrist extensors. B. Corticosteroid injection and complete immobilization. C. Activity modification, counterforce bracing, and eccentric strengthening of wrist extensors. D. Surgical debridement of the common extensor origin. Answer: C. Activity modification, counterforce bracing, and eccentric strengthening of wrist extensors. This question assesses the initial management of lateral epicondylitis, commonly known as tennis elbow. The concept involves understanding that this is typically an overuse injury characterized by microtears and degeneration, not acute inflammation. Keywords like initial treatment suggest a conservative, non-invasive approach. The most appropriate initial treatment focuses on reducing stress on the affected tendons through activity modification, example changing grip during repetitive tasks, supporting the area with a counterforce brace, and gradually building tendon resilience with eccentric exercises, example lowering a weight slowly. Immediate heavy strengthening could exacerbate the condition, and surgery is a last resort. For example, a therapist might instruct a patient to use a lighter hammer or adjust their tool grip. Remember, conservative management, especially activity modification and eccentric strengthening, is key for lateral epicondylitis. Question 6. A patient reports increased pain and swelling at the base of their thumb following repetitive tasks involving pinching and grasping. The Finkelstein's test is positive. What is the most likely diagnosis? A. Carpal tunnel syndrome. B. Trigger finger. C. De Quervain's tenosynovitis. D. Basal joint arthritis. Answer: C. De Quervain's tenosynovitis. This question tests your ability to diagnose de Quervain's tenosynovitis based on specific symptoms and a key diagnostic test. The important keywords are pain and swelling at the base of their thumb, repetitive tasks involving pinching and grasping, and a positive Finkelstein's test. De Quervain's tenosynovitis is an inflammatory condition affecting the tendons of the abductor pollicis longus and extensor pollicis brevis in the first dorsal compartment of the wrist, commonly caused by repetitive thumb and wrist movements. The Finkelstein's test specifically provokes pain in this area, confirming the diagnosis. For example, new mothers often develop this due to repetitive lifting of infants. Remember that pain at the radial styloid with a positive Finkelstein's test strongly indicates de Quervain's. Question 7. A patient presents with a mallet finger deformity. What is the recommended splinting position for the dip joint? A. Full flexion. B. Slight flexion, 10 to 15 degrees. C. Full extension. D. Neutral position. Answer: C. Full extension. This question focuses on the appropriate splinting technique for a mallet finger injury. The concept is to immobilize the distal interphalangeal, DIP, joint in a position that allows the disrupted extensor tendon to heal without tension. A mallet finger results from a rupture or avulsion of the extensor tendon at its insertion on the distal phalanx, causing the dip joint to droop into flexion. Therefore, the dip joint must be splinted in continuous full extension for typically 6 to 8 weeks, without allowing any flexion. For instance, a patient might wear a custom or commercially available stack splint. The key takeaway is that for a mallet finger, complete and constant dip extension is non-negotiable for proper healing. Question 8. What is the primary purpose of the intrinsic plus position, also known as the safe position, for hand splinting? A. To maximize grip strength. B. To minimize edema and prevent joint contractures. C. To facilitate immediate return to activity. D. To isolate specific muscle groups for strengthening. Answer: B. To minimize edema and prevent joint contractures. This question assesses the fundamental purpose of the intrinsic plus splinting position, a critical concept in hand therapy. The intrinsic plus position places the wrist in slight extension, the MCP joints in 70 to 90 degrees of flexion, and the IP joints in full extension. This specific configuration helps maintain the collateral ligaments of the MCP joints in a lengthened position, preventing them from shortening and contributing to MCP joint stiffness, a common complication of immobilization or edema. Additionally, elevating the hand in this position can aid in edema reduction. For example, post-operative hand surgeries often utilize this position to protect joints from stiffness. Remember, the intrinsic plus position is a safe position because it protects the critical collateral ligaments of the MCPs from shortening. Question 9. When evaluating grip strength, what is the standard position for the dynamometer handle? A. Handle set to position 1, narrowest. B. Handle set to position 2. C. Handle set to position 3. D. Handle set to position 5, widest. Answer: C. Handle set to position 3. This question tests your knowledge of standardized grip strength measurement protocols. The concept is ensuring reliable and valid data collection for comparison. The keyword standard position highlights the need for adherence to established procedures. For most adult patients, the standard position for the dynamometer handle is position 3, as this setting typically allows for optimal recruitment of the intrinsic and extrinsic hand muscles, providing the most accurate representation of maximal grip strength. Deviating from this standard can lead to inconsistent or misleading results. For example, therapists use this precise setting to track a patient's progress over time. Always remember that position 3 is the standard setting for routine grip strength measurements. Question 10. A patient presents with burning pain, allodynia, and trophic changes in their hand following a distal radius fracture. These symptoms are disproportionate to the original injury. What is the most likely diagnosis? A. Diabetic neuropathy. B. Carpal tunnel syndrome. C. Complex regional pain syndrome, CRPS. D. Brachial plexopathy. Answer: C. Complex regional pain syndrome, CRPS. This question describes classic symptoms of complex regional pain syndrome, CRPS, a challenging condition. The keywords burning pain, allodynia, pain from a stimulus that shouldn't cause pain, trophic changes, example changes in skin, hair, nails, and disproportionate to the original injury are all hallmark signs of CRPS. This syndrome involves dysfunction of the central and or peripheral nervous systems, leading to severe, chronic pain and various autonomic and sensory abnormalities, often triggered by trauma or surgery. For instance, a patient might describe their hand feeling on fire even with a light touch. Remember, when symptoms are excessively painful and include autonomic changes beyond what's expected for the injury, think CRPS. Question 11. Which nerve is most commonly affected in cubital tunnel syndrome? A. Median nerve. B. radial nerve. C. Ulnar nerve. D. Axillary nerve. Answer: C. Ulnar nerve. This question directly tests your anatomical knowledge of nerve compression syndromes. The concept is identifying which major nerve passes through the cubital tunnel. The cubital tunnel is a space on the medial side of the elbow where the ulnar nerve passes behind the medial epicondyle. When this nerve is compressed or irritated in this area, it leads to cubital tunnel syndrome, causing symptoms like numbness and tingling in the small finger and ulnar half of the ring finger, along with weakness in intrinsic hand muscles. For example, repeatedly resting the elbow on a hard surface can provoke these symptoms. Here's an easy way to remember it. Think ulnar for cubital, both names sound similar. Question 12. A patient with Dupuytren's contracture has undergone a fasciectomy. What is the primary focus of early hand therapy intervention postoperatively? A. Aggressive strengthening exercises. B. Immobilization in a flexed position to prevent stretching. C. Edema control, wound care, extension splinting, and gentle range of motion exercises. D. Application of heat modalities to increase tissue extensibility immediately. Answer: C. Edema control, wound care, extension splinting, and gentle range of motion exercises. This question focuses on appropriate postoperative management following Dupuytren's contracture release. The concept is managing soft tissue healing and restoring mobility while protecting the surgical site. A fasciectomy involves removing the diseased palmar fascia, and early therapy is crucial to prevent recurrence of contracture and manage common post-surgical issues. Key initial interventions include controlling swelling, edema, ensuring proper wound healing, preventing reflection contractures with extension splinting, and carefully initiating active and passive range of motion to promote tissue gliding and prevent stiffness. Aggressive strengthening or heat application too early could compromise healing. For example, a therapist might provide a custom extension orthosis and teach gentle finger glides. Remember, early controlled motion and edema management are vital after Dupuytren's surgery. Question 13. What type of orthosis is primarily used to apply a continuous, low-load stretch to a stiff joint? A. Static progressive orthosis. B. Static orthosis. C. Immobilization orthosis. D. Resting hand orthosis. Answer: A. Static progressive orthosis. This question asks about a specific type of orthosis used for joint stiffness. The concept is applying controlled, prolonged force to increase range of motion. The keyword continuous, low-load stretch is central to understanding the function of a static progressive orthosis. Unlike a static orthosis that simply holds a joint still, a static progressive orthosis applies a constant, non-yielding stretch to a stiff joint, and the tension can be gradually increased by the patient or therapist over time. This sustained stretch encourages tissue elongation and improves joint flexibility. For example, a static progressive elbow extension orthosis might be used for a patient with a post-surgical elbow flexion contracture. Remember, static progressive means a non-moving, adjustable force for gradual stretching. Question 14. Which functional assessment tool would be most appropriate for evaluating a patient's ability to perform daily living tasks after a hand injury? A. Dynamometer. B. Pinch gauge. C. 9-hole peg test. D. Disabilities of the arm, shoulder and hand, questionnaire. Answer: D. Disabilities of the arm, shoulder and hand, questionnaire. This question tests your knowledge of appropriate outcome measures in hand therapy. The concept is selecting a tool that assesses self-reported function in daily activities. The keywords functional assessment tool and ability to perform daily living tasks indicate a need for a patient-reported outcome measure rather than an impairment-based test. The DASH questionnaire is a widely validated, self-administered questionnaire that asks patients to rate their difficulty with various upper extremity activities and symptoms, providing a comprehensive score of functional limitation and symptom severity. While other options measure strength or dexterity, they don't capture overall functional impact on daily life. For instance, a patient can complete the DASH questionnaire to report how their hand injury affects tasks like dressing or cooking. Remember, the DASH is excellent for capturing a patient's perceived functional limitations. Question 15. A patient presents with a painful clicking or catching sensation in their finger during flexion and extension, sometimes leading to the finger getting stuck. What is the most likely diagnosis? A. Boutonniere deformity. B. Swan neck deformity. C. Trigger finger. D. Mallet finger. Answer: C. Trigger finger. This question describes the classic symptoms of trigger finger, also known as tenosynovitis. The concept relates to an inflammation and thickening of the tendon sheath, which prevents the flexor tendon from gliding smoothly through a pulley. The keywords painful clicking, catching sensation, and finger getting stuck are characteristic of the flexor tendon being restricted as it passes through the A1 pulley, leading to the triggering phenomenon. This condition often results from repetitive gripping. For example, a patient might have to manually extend their finger after it gets stuck in flexion. Always remember that the clicking or catching often felt in the palm at the base of the affected finger points directly to trigger finger. Question 16. What is the recommended approach for managing a patient with acute inflammation and severe pain in the wrist? A. Hot pack application and aggressive range of motion exercises. B. Immobilization, cold modalities, and elevation. C. Progressive resistive exercises. D. Deep tissue massage. Answer: B. Immobilization, cold modalities, and elevation. This question focuses on the acute management principles for inflammation and pain. The concept is reducing the inflammatory response and providing comfort. The keywords acute inflammation and severe pain indicate that the primary goal is to calm the irritated tissues and minimize further irritation. Immobilization helps rest the injured area. Cold modalities, like ice packs, reduce swelling and pain, and elevation helps decrease edema by promoting fluid drainage. Aggressive motion or heat would exacerbate acute inflammation. For example, a sprained wrist would benefit from these initial measures. Remember, the acronym RICE, rest, ice, compression, elevation, is a useful guide for acute injuries. Question 17. The primary goal of desensitization techniques for a hypersensitive hand is to A. Increase pain tolerance through noxious stimuli. B. Reduce nerve conduction velocity. C. Decrease the hand's reaction to normal sensory input. D. Promote sensory discrimination through object identification. Answer: C. Decrease the hand's reaction to normal sensory input. This question targets the core purpose of desensitization interventions in hand therapy. The concept is to recalibrate the nervous system's response to tactile stimuli. The keyword hypersensitive hand indicates that the patient is experiencing an exaggerated or painful response to ordinary touch, often following nerve injury or trauma. Desensitization techniques involve progressively introducing different textures and pressures to the affected area, gradually habituating the nervous system to sensory input that was previously perceived as irritating or painful. This helps the brain reinterpret the sensation as normal and non-threatening. For example, a patient might start by gently rubbing cotton on their hand and gradually progress to rougher textures like Velcro. Remember, desensitization aims to make ordinary touch feel normal again. Question 18. What is the primary blood supply to the hand and wrist? A. Brachial artery. B. Axillary artery. C. Radial and ulnar arteries. D. Subclavian artery. Answer: C. Radial and ulnar arteries. This question tests foundational anatomical knowledge regarding the vascular supply of the upper extremity. The concept is identifying the main arterial contributors to the hand circulation. While the brachial artery is proximal and supplies the arm, and the axillary and subclavian arteries are even more proximal, the radial and ulnar arteries are the direct and primary arteries that course into the forearm and then form the superficial and deep palmar arches, supplying the entire hand and wrist. These two arteries are crucial for maintaining viability and function. For example, a physician might perform an Allen's test to ensure patency of both radial and ulnar arteries before a procedure. Always remember that the radial and ulnar arteries are the lifelines of the hand. Question 19. A patient with carpal tunnel syndrome undergoes a surgical release. What is an appropriate post-operative activity modification instruction for the immediate post-operative period? A. Begin immediate vigorous gripping and lifting to promote healing. B. Avoid heavy lifting, prolonged gripping, and repetitive wrist flexion/extension. C. Immobilize the wrist completely in a full flexion splint. D. Engage in immediate return to all pre-injury activities. Answer: B. Avoid heavy lifting, prolonged gripping, and repetitive wrist flexion/extension. This question assesses appropriate post-operative precautions after carpal tunnel release surgery. The concept is protecting the healing tissues and preventing irritation of the newly decompressed median nerve. The keywords immediate post-operative period suggest a need for caution. After carpal tunnel release, the patient should avoid activities that put excessive strain on the surgical incision or irritate the median nerve, such as heavy lifting, sustained gripping, or extreme wrist movements. This allows the incision to heal and reduces the risk of scar tissue adhesion around the nerve. For example, a therapist might advise using the unaffected hand for heavy tasks or modifying how objects are carried. Remember, controlled activity and avoiding excessive strain are key for optimal healing after carpal tunnel surgery. Question 20. Which of the following conditions is characterized by thickening and shortening of the palmar fascia, leading to progressive flexion contractures of the digits? A. De Quervain's tenosynovitis. B. Trigger finger. C. Dupuytren's contracture. D. Ganglion cyst. Answer: C. Dupuytren's contracture. This question describes the hallmark features of Dupuytren's contracture. The concept involves recognizing the specific pathology affecting the palmar tissues. The keywords thickening and shortening of the palmar fascia and progressive flexion contractures of the digits are definitive descriptors of Dupuytren's, a condition where fibrous cords form in the palm and fingers, pulling them into a flexed position. This condition is distinct from tendonitis or cysts. For instance, a patient might notice a lump in their palm and an inability to flatten their hand completely on a table. Remember, Dupuytren's is all about the contracting fibrous tissue in the palm that pulls the fingers into flexion. Question 21. When designing a custom splint, which of the following is crucial to ensure patient comfort and prevent pressure sores? A. Using the thickest material possible. B. Ensuring proper padding over bony prominences. C. Making the splint as short as possible to allow maximum movement. D. Applying maximum tension initially to achieve rapid gains. Answer: B. Ensuring proper padding over bony prominences. This question focuses on essential principles of custom splint fabrication related to patient safety and comfort. The concept is minimizing adverse effects of orthotic use. The keywords patient comfort and prevent pressure sores highlight the importance of careful design and fit. Bony prominences, example ulnar styloid, radial head, are areas where skin breakdown and pressure sores are most likely to occur due to concentrated pressure from the splint. Therefore, strategic padding and ensuring the splint distributes pressure evenly are critical. Using overly thick material isn't necessarily better, and applying maximum tension can cause harm. For example, a therapist will often pad over the dorsum of the MCP joints when fabricating a wrist cock-up splint. Always remember that protecting bony prominences is paramount for preventing skin breakdown from splint wear. Question 22. What is the purpose of the modified Allen's test before radial artery puncture or cannulation? A. To assess for carpal tunnel syndrome. B. To evaluate the patency of the ulnar artery. C. To determine if the radial artery is occluded. D. To measure blood pressure in the hand. Answer: B. To evaluate the patency of the ulnar artery. This question tests your understanding of a critical vascular assessment tool. The concept is ensuring adequate collateral blood flow to the hand. The keywords modified Allen's test and radial artery puncture or cannulation point to the need to assess the hand's alternative blood supply. The test involves occluding both radial and ulnar arteries at the wrist, then releasing the ulnar artery to observe if blood flow returns to the hand within seconds. This ensures that if the radial artery is compromised, example by a puncture, the ulnar artery can adequately perfuse the hand, preventing ischemia. For example, a therapist or nurse would perform this test before drawing arterial blood from the radial artery. Remember, the Allen's test is all about confirming the ulnar artery's ability to supply the hand if the radial artery is temporarily blocked. Question 23. A patient demonstrates weak wrist extension and a wrist drop deformity. Which nerve injury is most likely causing these symptoms? A. Median nerve. B. Ulnar nerve. C. Radial nerve. D. Axillary nerve. Answer: C. Radial nerve. This question tests your knowledge of specific nerve innervation and common deformities associated with nerve injury. The concept is understanding the motor functions supplied by the major nerves of the upper extremity. The keywords weak wrist extension and wrist drop deformity are classic signs of a radial nerve injury. The radial nerve innervates the wrist extensors, example extensor carpi radialis longus and brevis, extensor carpi ulnaris, and finger extensors, so damage to this nerve results in an inability to extend the wrist and fingers, leading to the characteristic wrist drop. For example, a fracture of the humerus can sometimes lead to a radial nerve injury. Always remember, radial for wrist drop. Question 24. What is the primary purpose of applying gentle compression to a healing wound in the hand? A. To increase edema. B. To promote excessive scar formation. C. To reduce edema and promote organized collagen alignment. D. To prevent wound closure. Answer: C. To reduce edema and promote organized collagen alignment. This question addresses the therapeutic benefits of compression in wound care. The concept is managing swelling and scar quality. Gentle compression, often through elastic bandages or compression garments, is beneficial for healing wounds and scars in the hand. It helps to reduce post-surgical or post-injury edema, which can otherwise impede healing and lead to stiffness. Additionally, the sustained pressure helps to align collagen fibers during the remodeling phase of healing, leading to a flatter, less hypertrophic, raised scar. For example, a compression garment might be prescribed for a burn scar on the hand to minimize hypertrophy. Remember, compression is excellent for managing swelling and improving scar quality. Question 25. A patient complains of pain, numbness, and tingling along the medial side of the hand, involving the little finger and the ulnar half of the ring finger. What is the most likely site of compression? A. Carpal tunnel. B. Radial tunnel. C. Guyon's canal. D. Pronator teres muscle. Answer: C. Guyon's canal? This question tests your ability to localize nerve compression based on specific sensory distribution. The concept is understanding the anatomy of the ulnar nerve in the hand. The keywords pain, numbness, and tingling along the medial side of the hand, involving the little finger and the ulnar half of the ring finger, are the classic symptoms of ulnar nerve compression at the wrist. Guyon's canal is the anatomical passageway at the wrist through which the ulnar nerve and artery pass. Compression here causes symptoms in the ulnar nerve distribution distal to the elbow. For instance, prolonged cycling with pressure on the wrist can sometimes cause symptoms in Guyon's canal. Remember, if ulnar nerve symptoms are localized to the hand and wrist, think Guyon's canal. Question 26. Which splinting position is most commonly used to prevent adduction contracture of the thumb web space? A. Thumb in full opposition. B. Thumb in radial abduction and extension. C. Thumb in full flexion. D. Thumb in neutral position. Answer: B. Thumb in radial abduction and extension. This question focuses on preventing a common thumb deformity through proper splinting. The concept is maintaining the first web space to preserve thumb function. The keyword adduction contracture of the thumb web space indicates a shortening of the skin and soft tissues between the thumb and index finger, which can severely limit grasp and pinch. To counteract this, the thumb should be splinted in radial abduction, away from the palm, and extension, effectively stretching the web space and maintaining its width. This position is crucial after burns, trauma, or prolonged immobilization. For example, a C-bar splint might be used to maintain this position. Always remember that keeping the thumb abducted and extended is vital for preventing and treating first web space contractures. Question 27. When teaching a patient with osteoarthritis of the thumb CMC joint about joint protection principles, which activity modification is most appropriate? A. Use a pinch grip for all activities to strengthen the joint. B. Avoid using adaptive equipment. C. Substitute a power grip for a pinch grip whenever possible. D. Perform repetitive, forceful pinching movements. Answer: C. Substitute a power grip for a pinch grip whenever possible. This question assesses knowledge of joint protection principles for thumb CMC osteoarthritis. The concept is reducing stress on the affected joint to minimize pain and slow progression. The keywords osteoarthritis of the thumb CMC joint and joint protection principles highlight the need for strategies to offload the stressed articulation. The thumb carpal CMC joint is heavily loaded during pinch activities. Substituting a power grip, using the whole hand, like holding a mug with the handle in the palm, for a fine pinch grip, like twisting a small knob with thumb and index tip, distributes forces more broadly, reducing direct stress on the CMC joint. This helps decrease pain and inflammation. For instance, using an electric can opener instead of a manual one is a good example. Remember, offloading painful joints through activity modification is central to joint protection. Question 28. What is the primary purpose of performing sensory re-education after a nerve injury repair? A. To increase muscle strength. B. To reduce scar tissue formation. C. To improve sensory discrimination and re-establish functional sensation. D. To prevent joint stiffness. Answer: C. To improve sensory discrimination and re-establish functional sensation. This question focuses on the goal of sensory re-education, a crucial intervention after nerve injury. The concept is retraining the brain to interpret sensory input correctly following neural regeneration. After nerve repair, regenerating nerve fibers may misinterpret sensations or produce distorted perceptions. Sensory re-education aims to help the brain reorganize and interpret new sensory information, distinguishing between different textures, pressures, and temperatures, thereby improving functional sensation and safety. This involves a progression of tactile tasks, often starting with light touch and advancing to more complex discriminations. For example, a patient might practice identifying objects in a bag without visual input. Remember, sensory re-education is about helping the brain rewire and properly interpret touch after nerve damage. Question 29. A patient has undergone a flexor tendon repair in zone 2 of the hand. What is a key principle of early mobilization protocols for this repair? A. Complete immobilization for 6 to 8 weeks. B. Aggressive passive range of motion immediately. C. Controlled active motion within a protected range, often with a dorsal blocking splint. D. Weight-bearing activities to promote tendon strength. Answer: C. Controlled active motion within a protected range, often with a dorsal blocking splint. This question assesses knowledge of flexor tendon repair rehabilitation, specifically for Zone 2, no man's land, injuries. The concept is balancing protection of the repair with controlled movement to prevent adhesions. The keywords flexor tendon repair in Zone 2 indicate a complex area prone to dense adhesions. Early, controlled active mobilization protocols, example Duran or Kleinert protocols, are now standard. These protocols use a dorsal blocking splint to limit extension and protect the repair, while allowing specific, gentle active flexion exercises to promote tendon gliding and prevent excessive scar formation. Complete immobilization leads to severe stiffness. For example, a patient might perform gentle hook fisting exercises within the splint. Remember, controlled active motion within a protected range is vital for successful flexor tendon repair outcomes. Question 30. Which condition typically presents with morning stiffness, symmetric joint involvement, and can lead to ulnar drift of the fingers? A. Osteoarthritis. B. Gout. C. Rheumatoid arthritis. D. Psoriatic arthritis. Answer: C. Rheumatoid arthritis. This question describes classic characteristics of rheumatoid arthritis, RA, a systemic inflammatory condition. The concepts being tested are the key differentiating features of inflammatory arthritides. The keywords morning stiffness, symmetric joint involvement, and ulnar drift of the fingers are highly indicative of RA, morning stiffness lasting over 30 minutes, involvement of the same joints on both sides of the body, and characteristic deformities like ulnar drift, deviation of the fingers towards the ulnar side, are hallmark signs of this autoimmune disease. Unlike osteoarthritis, which is typically asymmetric and less inflammatory, RA is a chronic inflammatory condition. For example, an individual might report significant difficulty with fine motor tasks in the morning due to hand stiffness. Remember, symmetric inflammatory joint pain with prolonged morning stiffness and classic hand deformities strongly points to rheumatoid arthritis.